A pleasant day to everyone. I am Dr. Ryan Martin Co, and our topic for today is about diseases of the nose and the paranasal sinuses. Our objectives for this lecture would be to identify the different common diseases by knowing the pathophysiology and clinical manifestations, and to plan and formulate the management by getting the appropriate diagnostic modalities and treatment. We will categorize the diseases according to infections, inflammatory, bleeding disorders, and neoplasia. Rhinosinusitis is a group of disorders generally characterized by inflammation of the mucosa of the nose and paranasal sinuses. We classify this into acute if the condition is less than 3 months and chronic if it persisted for 3 months or more. The most common cause of rhinosinusitis is still viral. However, if it remains for more than 10 days, or if there is worsening of condition after 5 to 7 days, then the probability of acute bacterial rhinosinusitis is considered. The most common etiologic organisms in bacterial rhinosinusitis are Staphylococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. In order to diagnose rhinosinusitis, you must have at least 2 major criteria or 1 major and 2 minor criteria. Treatments for rhinosinusitis include nasal irrigation or nasal douching, as shown in the video, nasal decongestants not more than 5 days, analgesics, antibiotics, optional intranasal steroids, or sometimes even sinus surgery. Under inflammatory, let us discuss first allergic rhinitis. Allergic rhinitis is a hereditary chronic IgE-mediated inflammation of the nasal mucosa, with symptoms of frequent rhinorrhea, sneezing, nasal itching, nasal congestion, and ocular symptoms triggered by allergens. This is a type 1 immediate hypersensitivity reaction. This illustration simply compares a normal nose and paranasal sinuses and a nose suffering from allergic rhinitis with diffuse mucosal edema, nasal congestion, and thick mucus discharge. This slide shows the different signs observed in a patient with allergic rhinitis. The allergic shiners, which is the hemosiderin deposition and dark discoloration of the lower eyelid. The Denny-Morgan lines, allergic conjunctivitis, and allergic salute due to constant nasal itchiness. Upon physical examination, you can identify pale, buggy, hypertrophic turbinates with clear or whitish discharge, as well as cobblestoning at the posterior pharyngeal wall. With the WHO classification, we classify allergic rhinitis according to duration and frequency. Intermittent if it occurs less than 4 days per week or less than 4 weeks. Persistent if it occurs more than 4 days a week or more than 4 weeks. For according to severity, it will be mild if there is unaffected quality of life, while it will be moderate to severe if there is a decreased performance in daily activity, hence the quality of life is affected. According to local studies, the most common allergens are dust mites and cockroach elements. It is important to treat allergic rhinitis because it may lead to different diseases if left untreated. Allergic rhinitis can be diagnosed by history and physical exam alone. If the patient has nasal congestion, itchiness, sneezing, rhinorrhea, and ocular symptoms, but getting diagnostic tests may determine the allergen and strengthen your diagnosis, although these are all expensive tests. I have to overemphasize that the main management of allergic rhinitis is to avoid exposure to allergens, and pharmacotherapy and immunotherapy are there to help control the allergic reactions. Non-allergic rhinitis has similar symptoms to allergic rhinitis, although skin test and IgE test are negative. It is usually known to be induced by irritants rather than allergens. Treatment includes address or stop the cause, regular exercise, sleeping with head elevated, nasal saline spray or nasal douching, and intranasal steroids. Polyp formation. A nasal polyp is the most common mass lesion of the nasal cavity due to chronic inflammatory disorder of the nasal and sinus mucosa. It is a benign outpouching of the mucosa covering the ethmoid or maxillary sinuses. On direct visualization, there are round, moist, grape-like gelatinous or fleshy pedicled masses that can reach up to the naso and oropharynx. They may also become hemorrhagic from local chronic irritation and infection. How do we distinguish a polyp from a turbinate? Please study this important table to have a guide when examining the nose of your patients. There are usually two types of nasal polyps. It could either be a nasal polyposis, which is bilateral, and anthrochoanal polyp occurring in a nasal cavity. The difference in the management of these nasal polyps are nasal polyposis can still be treated medically if the size is small, but anthrochoanal polyps are treated surgically. Our next topic is considered to be one of the ENT emergencies. Epistaxis affects up to 60% of the population. It is less frequent in females due to estrogen. And most of the time, it is idiopathic. Although in children, it is usually secondary to trauma by nose picking and wounding the highly vascularized nasal mucosa. The vascular-rich nasal cavity aids in humidification and thermoregulation of air. Anteriorly, the Kesselbach's plexus is involved in anterior epistaxis, and the Woodruff's plexus in the posterior epistaxis. This illustration shows the area where the Kesselbach and the Woodruff's plexuses are located. Clinically, anterior epistaxis is nose bleeding coming out of the nostril, while posterior epistaxis is the bleeding from the nasal cavity going down to the throat. The causes of epistaxis includes trauma, inflammatory disease, systemic disease, substance abuse, and neoplasm. Trauma to the nose may result from manipulation, nasal intubation during oral surgeries, foreign bodies, fractures, CPAP, and nasal surgery. Inflammatory disease such as mucositis causes engorgement of blood vessels, which easily bleeds if irritated. Systemic diseases include hypertension, drug-induced, or blood dyscrasia. When managing these patients, referral to internists and pediatricians are often needed. Substance abuse such as cocaine can cause septal perforation by severe vasoconstriction leading to necrosis. And lastly, epistaxis is also seen in sinonasal tumor such as angiofibroma, inverted papilloma, and squamous cell carcinoma. When doing first aid, it is imperative to apply digital pressure at least 20 minutes while maintaining the head to lean forward position. If persistent, an emergency room visit is paramount for complete physical examination with nasal endoscopy and possible nasal packing or diagnostic workup. The different management includes vitamin K and tranexamic acid while discontinuing any medications that may cause bleeding, silver nitrate cautery, monopolar and or bipolar cautery, and more invasive procedures such as embolization and vessel ligation. Please familiarize yourselves with this algorithm for the management of epistaxis. The last topic for today will be on neoplasia, benign and malignant tumors. Inverted papilloma or Schneiderian papilloma is the second most common benign neoplasia in the nasal cavity. This is more common in males and typically arises from the lateral nasal wall. It is also associated with HPV infection and has a tendency to transform into squamous cell carcinoma. Patient in general will present with unilateral nasal obstruction, watery rhinorrhea, minimal epistaxis, and for large tumor, it may present with diplopia, epiphora, proptosis, and headache. The diagnostic tools needed for this problem are punch biopsy, CT scan with contrast, MRI with gadolinium for preparing and planning prior to surgery. And the ideal surgical procedure for this is medial maxillectomy, meaning removing the medial wall of the maxillary bone. The next benign neoplasia is what we call the juvenile nasopharyngeal angiofibroma or JNA. This is a benign tumor usually found in adolescent male, probably due to entrapment of embryologic vascular tissue in the cartilage. Histopath findings composed of large blood vessels without tunica media. Like in these pictures, the lower left shows normal blood vessels, while on the right you can clearly appreciate the absence of smooth muscle layer, thus its inability to vasoconstrict. Clinically, patients would present with profuse epistaxis, nasal obstruction, middle ear effusion, conductive deafness, hyponasal speech, proptosis, and bulging of the cheek. On physical examination, A reddish globular mass should be seen in the nasopharynx. Angiography is requested to locate the feeding vessel, and embolization may be performed before the operation. Part of the preoperative preparation is getting a CT scan of the paranasal sinuses, where Holman-Miller sign or the anterior bowing of the posterior maxillary wall can be spotted. The definitive treatment is complete excision, usually via lateral rhinotomy. Malignant tumor of the nose and paranasal sinuses. This condition almost exclusively occurs in males over 50 years old with a squamous cell carcinoma type. Similarly, the paranasal sinuses cancer is nearly identical statistically speaking. The most common site involved in the nasal cavity is the lateral wall, while the most common sinus involved is the maxillary sinus. Risk factor is usually due to smoking and alcohol intake. Signs and symptoms can be confusing, as these manifestations may be seen in a benign tumor. However, lymph node metastasis would be indicative of malignancy. The Ongren's line is an imaginary line drawn from the inner canthus to the angle of the mandible. Any tumor occurring superior and lateral to this line would have a poorer prognosis. Management would still require biopsy and imaging studies, but the surgical approach is way more intensive depending on the extent of cancer. This includes possibility of combination radiation and chemotherapy. Thank you and